cycle. Basically, it'll be all review for you ladies. It's very similar to what you were taught in 5th grade. But we're just throwing in all those different hormones and negative feedback and positive. Okay, it'll be a lot different than 5th grade. Okay. But this is actually pretty good in a sense that it's going to help you to review for the final exam. The final exam, which is happening in a couple of weeks, is going to deal with, we've been, this is like, this is the last chapter of our book, pretty much as development, but all throughout A&P2, we've been talking about all the different kinds of hormones. So this is no exception. So I'm going to continue with that, but I'm going to show you now how negative and positive feedback is going to play a role in this. Also positive feedback also. So let's get into the menstrual cycle. All right. So this is the physiology of women, so to say. Now, the normal cycle. I understand that every woman in here or women that you know, they have their different cycles, meaning they last longer than what usually should be, or they a little bit less. But for this course, we're just going to deal with the run-of-the-mill menstrual cycle. We don't need to go into the details of how things can go different, but we got to stay on one page. So the normal cycle is 28 days plus or minus 7 days. So yes, you can have a normal menstrual cycle anywhere from 21 to 35 days. But we're going to use 28 as our magic number. Okay, we'll base everything on that. Okay, throughout this course. Menses, or menstruation, is when bleeding occurs and it happens for 5 days, the first 5 days of menstruation. Now, when a woman bleeds, they're going to bleed about 30 to 80 milliliters per cycle. So, let me just give you an example of what I mean by this. All right? Whatever. None of you have a bottle of water? That's something you're more familiar with. Okay. So, this here, bottle of water is 500 milliliters. Okay? 500 milliliters. What I'm saying is, we break this up into 5 sections, so this will be 100 milliliters. Now, a normal menstrual cycle, you're going to lose less than that for the whole 5 days. Don't start throwing tomatoes at me. I'm just saying, okay? Less than that. That's what a normal menstruation is, okay? Very, very little, okay? There shouldn't be any clots there. In fact, what happens here, thank you, what happens here is this. When clots form, they shouldn't be there. But if you're bleeding more than usual, you're sitting down and the blood is coming down and sitting in the bottom of the vagina. So now it's going to coagulate. So when you get up, a clot comes out. But it should only trickle very little out of the cervix. Okay? So clots are abnormal. Now, when I say abnormal, if you've been having clots throughout your whole lifetime and it doesn't affect you and you're fine with it, what I mean by it doesn't affect you is that you don't feel so weak that you can't even go to work, you can't do your normal daily activities, then that's a problem. But if it's clots where, you can still do things and it's not so much of a worry, and to you that's normal, then that's fine. But when it becomes a problem is when you start not being able to do certain things. And easily said, gynecologists, we can fix that. All right, we can make it so there won't be so many clots. We got to figure out what it is. Is it something organic, like a fibroid uterus, or is it something that's not so organic, that it's hormonal? Something that's more pretty common is something called dysfunctional uterine bleeding, which is telling you that the progesterone and estrogen are not in sync, and it's causing you to have bleeding. So we could give you birth control pills to get it back on track. Okay, so that's another topic for another time, but I just wanted to go a little bit more into that since my background is gynecology. All right, so that's what that is. So just understand, 30 to 80 milliliters of blood usually occurs during menstruations per cycle, not per day, per cycle for the 5 days. And the last menstrual period, when someone asks a woman, when's your last menstrual period? It's the date of the first day of your bleeding. Okay? Most women understand that. Guys, even if, whether they care or not, they might not understand it. But this is important. All right? When radiologists ask a woman, when was your last menstrual period, we need to make sure you're not pregnant before we're going to shoot you with all these x-rays, right? That's where it comes in. And also to find out if you are pregnant, how old is the gestation. So if you have a period, I'm making the numbers easier for you. If you have a period, let's say this is, I'm just going to make it easy. January 1 through to the 1st, you have a period. And then no period until January 29th, 30th, 31, February 1st, February 2nd. Then no period, and you visit your doctor on February 15th. He's going to ask you, or she's going to ask you, today's February 15th. What's the day of your last menstrual period? What day would you give them? You have to say, this is what your cycle is. You bleed January, I'm just giving you an example. January 1st, 2nd, 3rd, 4th, 5th, nothing until January 29th, 30th, 31, February 1st, 2nd, and no period, and now you're visiting your doctor on February 15th. She's going to ask you, when was your last menstrual period, your LMP? In one date, you are going to say, when was your last menstrual period? You women probably know, but what about the guys? What do you tell them? Yeah. What day? The 29th. Who here says the 29th? The first day of your last, it's the first day of your last time, the first day of the last time you bled. So I bled on these days here, not me.
So it's second.
No, it's this day. It's the first day of your last menstrual period.
Okay.
Does that make sense? In fact, when I ask patients that, I don't say when your last menstrual period is, because you could imagine all the different answers you're going to get, and that's not going to help. So I just literally say, when was the first day of your last menstrual period? Now there's no question. Not asking the last day, I'm asking the first day of your last menstrual period. And that's the way, as medical professionals yourselves, should be asking. Don't ask when your last menstrual period is, because a lot of people have different definitions of that. In the medical realm, there's only one definition. But layman, there's many definitions. Is that clear about that? Questions? Okay? All right. So that's a little bit about that part. Okay. Now, basic terms. And this is some review for you. Okay? A follicle is an egg sac and contains a maturing egg. Many grow at one time until after about a week, most of them, all of them will start regressing and dying except for one. That one's going to grow to a mature follicle, right? A graphene follicle, and eventually going to pop out of the ovary. Ovulation. That's the time that the egg ruptures out of the ovary, right out. That will happen on day 14, plus or minus 3 days. But our classic thing is day 14 when we're dealing with a 28-day cycle. So we're all on the same page. Does that make sense? It does vary, though, which might explain why we have a lot of unplanned pregnancies. Okay? Once the egg pops out of the ovary, the area, the region where that egg popped out of is a critical thing. It turns into a gland and is known as a corpus luteum. Luteum meaning yellow, corpus meaning body. And that's going to start secreting certain hormones. That will continue to grow and secreting hormones for about a week or so. And if the egg gets fertilized, it will continue to grow and release hormones. But in most cases, you're not going to get pregnant, right? Every woman doesn't get pregnant every month. Doesn't happen, right? So this starts dying down to a scarred white area known as a corpus albicans. Albicans, think of albino, white. And it doesn't function. This is basically what happens. There's a close-up of it. Here's the fimbriae of your fallopian tube. Here's the ovary, and here's where it just pops right out. That's a good picture for hanging fireplace mantle. Here's another good picture. There's the ovary, and here's a corpus luteum. See the yellow color to it? All right? Very hard to find that, believe me. I wish I took that picture. That's not mine.
Huge compared to the...
Yeah, it's a big gland. Mm-hmm. But keep in mind, the ovary itself is about the size of an olive.
Right. But in comparison to the ovary...
Yeah, that's pretty big. It's got to produce a lot of hormones to keep that pregnancy going. But even that, as the pregnancy gets bigger, there's not enough hormones that come out of there. So we're going to have another source to keep that pregnancy going. So, menses, menstruation, the shedding of the tissue, and what follows is the blood. You see the blood, but it's really the endometrial lining that's shedding off in preparation for the next, in preparation of an implantation of the next ovulation, all right? See, every cycle, it assumes you're going to get pregnant. So it always has to prepare. It never gets pregnant. I don't say it's dumb, but it has to prepare every time to give a nice, clean endometrial lining for hopefully a new implantation of a pregnancy to go in there, okay? Menarche. This is the first time you had your first period. Usually, during puberty, and it's usually between 9 and 15 years old with an average age of almost 13 years old, okay? Then we also have menopause. That's when all the eggs have been depleted. And you have scanty menses, meaning scanty, very little, and they're irregular. Maybe you have a menstruation in January, then nothing in February or March, and you have another one in April, and in May you get one, but then you don't have one for the next 3 months. They're scanty. Does that make sense? And that average age is about 50 years old. Okay? We actually call it postmenopausal once you not have a menses for 1 year. Then you're postmenopausal. I kind of explain this to patients, and I think you could understand this too. The way ovulation occurs through a woman's life, a girl's life, is kind of like making popcorn. Okay? Even though you have a menstruation, and this is too far of an explanation to I can't really get into details about it, but just because you have a menstruation does not mean that you have that your egg ovulated. In most cases it does, but not always. Okay? And likewise, if you don't have, you can still ovulate if you don't have a menstruation, because of certain diseases and conditions that would do that. But normally you wouldn't. So this is what I usually tell you. Early on, 13, 14, 15 years old, you might not be ovulating every month. But then during your childbearing age, meaning usually around 20s and 30s, it's like every month, and then it slows down again. So it's kind of like making popcorn. You put the popcorn bag in the microwave, and you put it on for 4 minutes, and all of a sudden it's going pop, 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 pop. Pop, 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 right? So the little short bursts is like early on, like 13, 14 years old, and then there's one all the time, and then what happens at the end? Pop, 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 right? And that's what happens at the end, about like 48 years or so. You don't ovulate all the time. I'm not saying menses, I'm talking about ovulation. Okay? Does that make sense? That's how I usually explain it to the patients. Okay. Now, review of some homeostasis. Okay? Homeostasis, all right? Values of variables fluctuate around a set point. This is old stuff. These slides here are you'll see them in endocrinology, so let's do a review. What happens here is that this determines a normal range of values, right? If your body temperature is supposed to be 98.6, that's a set value. But if you're 99.0, that's still normal. You still have a range of normal values around there, okay? So you have this desired value, and then you have a normal range around it, right? So that's what we have here is homeostasis. You want to stay around there. So we have two things. We have negative feedback, and negative feedback is any deviation that occurs, and it's going to try and bring that deviation closer to the set point, right? So if your body temperature is supposed to be, well, let me use a glucose as an example, okay? If your glucose is supposed to be 100, and now it goes to 120 and 140, negative feedback is going to say we got to bring it closer to 100. If your glucose goes to 90, 80, 60, negative feedback is going to bring it back to 100. That's what negative feedback does. It makes the distance from where it is to the set point smaller. Okay? That's what negative feedback does, and that's mostly what occurs in our body. But we do have conditions where it's going to be more of positive feedback. The reproductive endocrinology is showing that. What that is that positive feedback is that if let's say your glucose is supposed to be 100, and now it's 120, and then it's 140 and 160, 180, it's going further and further, and nothing's bringing it back to the midpoint or the set point. So it's going further from the set point, making that distance farther from the set point, okay? Now, in certain cases, that doesn't make sense to do. For instance, when we have to deal with a cervix opening to allow the baby to come out, the set point is the cervix is supposed to be closed. But as the baby pushes out, it's got to open. It's going away from the set point. 1 centimeter, 2 centimeters, 3 centimeters, until a baby can come out. It's going to go back to the brain and say, oh, baby's coming out, we're going to give you more pain, so that it stretches more. But the baby's trying to come out, we'll do more. It's going further from the set point. Does that make sense? Right? So that's positive feedback. But I'm going to show you also positive feedback for the menstrual cycle. Okay? So positive feedback is not as common as negative feedback. So let's just show you negative feedback. If the set point is, let's say, 22 degrees Celsius, they're using Celsius on here. Anything that's going to bring it back to the set point is going to be negative feedback. Positive feedback, like I said, is the cervix, is a good example where the cervix gets big. And you can do this on your own. It's just going to make that cervix open up, all right? Because that's going further from the set point. Now, let's review a few things about hormones, okay, when we're dealing with reproductive. GnRH, gonadotropin-releasing hormones, okay? Gonadotropin, that should help you, right? Gonad, has something to do with sexual orientation, sexual organs, right? Gonads. Releasing hormone, releasing. Any hormone that has the word releasing or inhibiting comes from the hypothalamus, okay? It gets secreted from there. So this is GnRH coming from the hypothalamus, and most hormones that come out throughout your whole body come out continuously in a smooth fashion, all right? It could go faster, it could go slower, but it's going in a smooth fashion. GnRH also does this, but it also does it in a pulsatile fashion. What I mean by that, these little surges, it can do like this. Pop, pop, pop. So these cyclic kind of pushes out. So stop and go, stop and go, stop and go. And that's critical because in certain hormones, when they see this pulsatile thing, it actually comes out much higher. So if GnRH comes out in a pulsatile fashion, it doesn't always go through pulsatile, but when it does, then LH gets released, luteinizing hormone, at a much higher rate, though. Okay? If GnRH comes out continuously, smooth, then LH comes out, but it doesn't come out so high. So this pulsatile amount that's coming out, or this pulsatile fashion, is controlling things. So this GnRH is going to control not just LH, but also controls FSH. But the FSH has no bearing of the pulsatile fashion that GnRH does. Only one is that LH does. Now look what's going to happen here. Remember, LH is going to cause ovulation. That's the one, the hormone that's going to cause ovulation. We'll get into that. So what's happening here, this is showing you the way GnRH comes out, gonadotropin releasing hormone. In the fetus, it's kind of smooth, but goes fast and then back down. And it's continuous over here. When it's continuous, FSH, there's more FSH that's going to come out than LH. Again, GnRH is going to make FSH come out, GnRH is going to make LH come out. But when it's continuous, FSH is more prominent of the two. Puberty, it's still going in a smooth fashion, a little faster, but smooth fashion. But now in the reproductive period, it comes out, GnRH comes out in a pulsatile fashion. When it does, LH comes out more than FSH. And then during menopause, it goes back in a continuous fashion, so FSH there's more than LH. And like I said, LH is going to stimulate, is going to cause ovulation, to make that egg rupture out. So this is where the egg is going to rupture out during those stages. Question?
No.
All right? Does that make sense? The pulsatile, the cyclic kind of pushing of this. Okay. FSH, follicle stimulating hormone. The name kind of implies what it's doing. It's going to stimulate follicles to grow, right? Follicles are egg sacs that hold the eggs. So this is going to stimulate the ovaries to make those follicles grow. Okay? And with the help of LH, it also comes out of the anterior pituitary, it's going to make the ovaries release estrogen. We have LH, luteinizing hormone. That's from the anterior pituitary also. Gets stimulated by GnRH. And this is going to stimulate the ovaries to trigger ovulation when it's at high levels. And it's also going to make the ovary or corpus luteum, once that happens, release progesterone. Okay? We have estrogen. Estrogen is from the ovarian follicles that you just saw, and also the corpus luteum. Once that egg pops out, the area that is now the corpus luteum is going to release estrogen. And FSH really was the one that did this. Now, estrogen is going to do everything in its power to cause fertilization. This is the Cupid hormone of your life, right? This is the one that's going to try and make the sperm meet up with the egg. It's going to make the acidity in the vagina better for the sperm to deal with. It's going to make the cilia being able to move better in the fallopian tubes to get the egg towards the sperm. Go ahead. You can go. He's a nice guy. Go ahead, right? Estrogens are a little Cupid. It's going to do everything it can to try and get the two to meet. Okay? Then we have progesterone. Progesterone is from the corpus luteum and the placenta. And I have to add, too, that estrogen also comes from the placenta. You might want to add that. So progesterone comes from the corpus luteum and the placenta. So yes, the placenta is an organ. It's a gland. It's stimulated by LH, and this is going to favor implantation and to maintain the pregnancy. So it's going to make sure that the endometrial lining continues to grow and to be good and have good glands there, so that and there's what we call there's certain glands, spiral glands, that actually are in the endometrial wall to allow the implantation of the embryo to go in with good efficiency. So it's doing everything it can to keep the pregnancy going. It's also going to prevent another egg and sperm to meet. In other words, we don't want to have two pregnancies happen at the same time, but at different times. Meaning, we don't want to have a pregnancy in you that's 3 months pregnant, and then you get pregnant again. So you have a 3-month pregnancy and you got a 0-month pregnancy. Does that make sense? That's not going to be good. The reason why is because there's certain things that happen to the body, the woman's body, to deal with a first, second, and third trimester pregnancy that is going to hurt. Let's say the woman's body for the third trimester is going to hurt a baby growing in the first trimester. So it's not going to be conducive. So we need to make sure, if progesterone is supposed to maintain a pregnancy, it needs to make sure that no other pregnancies occur during that pregnancy. So what is it going to do? It's going to prevent ovulation from happening for the next 9 months. Research people got a good idea about this early in the 1900s and said, well, if we could somehow put that in a pill form that it won't make you ovulate, and we put it in your mouth, then you won't ovulate. This could be good for birth control. And that's where that whole thing came up. So birth control pills have to have progesterone in it. And the progesterone is going to prevent the egg from ovulating, or prevent the ovary from ovulating and releasing an egg. That's how birth control works. Hint, hint, you might want to jot that down. Yes?
So, if LH stimulates ovulation and progesterone stops ovulation, I mean, it like inhibits LH?
Mm-hmm. Absolutely, it's a mimic. It mimics it, right?
Oh,
we're going to get into it. Well, not mimics, but we're going to talk about that. I don't know if we'll get to it today, but we'll talk about that. You can see where this is all. Keep your eye on all these different hormones because they're all going to interplay here. Okay? Questions about that? All right. So here's an overview of the 28-day cycle, and we'll go more into detail about it. There's 2 cycles going on in the menstrual cycle. We have to look at what's happening with the endometrial lining of the uterus as that changes throughout the 28 days. And because you don't bleed all for 28 days, you only bleed for 5 days. So something's happening, something stops and something's going on. So we got to talk about that. And then we got to talk about what happens with the ovary. I mean, it's not just there's an egg there, it pops out and now it's turning into another gland, it's going to release hormone. So there's a cycle that goes on in the ovary, and there's a cycle that goes on in the uterus or endometrial lining. So there's 2 things that are happening here. So this is just an overview. The endometrium, the uterus, has its own cycle, and it's affected by 2 hormones, estrogen and progesterone. That's what's up here. Okay? Day 1 through day 5, that's the menstrual phase of the endometrial cycle. This is the time you bleed. Then the bleeding stops. And now the endometrial lining needs to grow a little bit. We call this the proliferative phase. Proliferation means to make more of. You know, if you're going to proliferate your army, you're making more of your army, right? Then on day 14, the egg pops out of the ovary. That's the ovulatory phase. The corpus luteum is born right after that ovulation occurs, and it releases progesterone and estrogen. That's going to make glands in the endometrial lining start to grow. We call this the secretory phase. Secretory because glands secrete. Then, if there's no pregnancy that's going to happen, that corpus luteum starts dying down, and estrogen and progesterone start disappearing, so the endometrial lining starts dying. Less blood flow to it. We call this the ischemic phase, and it's day 27 and 28. Less blood flow. The blood vessels are not carrying nutrients and oxygen and blood to there, and it starts dying down. And when it starts dying down on day 1, you start having your period again. Now, if you get pregnant, in other words, there is fertilization that takes place, it usually happens on day 21 of the cycle, then we call this the gravid phase. Gravid means pregnancy. And that gravid phase of the endometrial cycle starts on day 21 and ends 9 months later when you deliver the baby. The gravid phase stays throughout the next 9 months. Okay? But the gravid phase only happens if the egg is fertilized. So this is what happens with the endometrial cycle. Okay? In the ovary, it's a bit shorter. Well, there's only 2 phases to be concerned about. There's still 28 days, but there's only 2 phases. It's affected by FSH and LH, not estrogen and progesterone as the endometrium is. FSH and LH target the ovaries, and that's broken down into 2 phases. The follicular phase, when the follicles are growing, that's day 1 to 13. Then the egg pops out. When the egg pops out, the corpus luteum is born in the ovary. We now call it the luteal phase. Thus the name luteal. Corpus luteum, luteal. And that happens on day 14 to day 28. Okay? Question, that's just an overview. I would make sure you know this. You should know the days. You should know what they're called. You might have to reproduce it on a test. All right? But you're also going to refer to this because you're going to have to answer questions about the menstrual cycle. And this always keeps you in line. If you have this written down, you can always go back to it and say, where am I on the cycle to answer this question? Okay? Kind of like the cardiac cycle, when you had that test on there, and dealing with questions about, if the pressure in the left ventricle is higher than the pressure in the left atrium, which valve is closed or shut. You're going to go back to that list of the blood trace through the heart, and I would say you would probably want to do the same thing here. Okay? All right. Let's look at the endometrial cycle. Go step by step. I'm going to go very slow for you, as much as I went slow with you with the cardiac cycle. Okay? So I want you to really get this. I'm going to talk about different hormones, as I just mentioned before, and how they interact with each other and what they do. I'm going to talk about positive and negative feedback. Okay. Day 1 through 5. At this point, there's no corpus luteum. And we'll explain what happens to the corpus luteum when we get to day 27 and 28. And so, but we have to start someplace. So let's start with day 1. Day 1 through 5 is what we call the menstrual phase. Now at this point, the corpus luteum normally would put out estrogen and progesterone, but there is no corpus luteum, as I'm stating here. So therefore, the estrogen and progesterone is going downward. There's a decrease of estrogen and progesterone, okay? And because the estrogen and progesterone normally keep a nice, healthy, thick endometrial lining, with estrogen and progesterone that has a diminished amount of it, low levels of it, this is where the endometrial lining is shedding off. So we're having a breakdown of the blood vessels that would normally go to endometrium. The endometrium sheds off, and the blood vessels are now open and releasing blood. So this is the shedding off of the tissue and the blood flow during menstruation. And it's because we have low levels of estrogen and progesterone. We say that the endometrial lining sloughs off or sheds off. Now, because we have low amount of estrogen and progesterone, we need to bring that back up. Estrogen comes from follicles. So the body starts understanding that if we don't have estrogen, maybe we should grow the follicles so that we can get more estrogen. Does that make sense? So it does what we call negative feedback to get the estrogen levels back up. It's going to send a message to the hypothalamus to release GnRH, and it's going to send a message to the anterior pituitary to release FSH. Okay? So now levels of FSH are going to go up. Because GnRH is going up, LH is also going to go up too. So now we have high levels of FSH, high levels of LH. this is what we have. This is the reason why, is because negative feedback, because we have low levels of estrogen and progesterone, right? Let me just do this, something we did a long time ago. What's happening here is that GnRH normally comes out of here, right? Out of the hypothalamus. That tells the anterior pituitary to release FSH and LH. If it comes out continuously, the GnRH, then the FSH is higher than the LH. If it comes out impulsatile, as I explained to you before, then LH is going to be higher than FSH. They're both coming out, it's just which one comes out higher. Okay? These will affect the ovary. If we increase FSH, then estrogen is going to come out. Okay? So, if all of this comes out, if there's an increase of this, there's an increase of this, there's an increase of this. If you make too much of this, it's going to tell this to lower and this to lower. Is that on? Make sense? Negative feedback. We're supposed to have, let's say, I'm just giving you numbers, 100 units of this, and now we have 150 units. It's going to send a message to here and a message to here to say, hey, look, slow down, we don't need that. And then the levels will decrease over here. Does that make sense? But now we have this situation. Estrogen is very low because the source of it is not producing that much estrogen and progesterone. So because it's low, it's going to send negative feedback to these areas here to increase this and increase this. Does that make sense? So that we can grow more follicles to make more estrogen. This is negative feedback. Okay? And now the follicles are going to start growing because of FSH, follicle stimulating hormone. The name tells you what they do. These are going to grow, and it's going to produce a lot more estrogen. You clear with that? That's what happens during menstruation. You have a low level of estrogen, and this hormonal negative feedback is going to be happening. Eventually, day 4 or 5, the menstruations will slow down because we have enough estrogen now in the body to slow it down. Okay? So let me show you what's going on with this graph. This is the endometrial lining, and I'm here showing you day 1, 2, 3, 4, 5. And I'm showing 6 up there also, just so you can see the next day after. And you can see the endometrial lining is shedding day by day and bleeding. It's going down. Day 1, 2, 3 up here at the ovary, there's no follicles. About 4 or 5 follicles are starting to develop because FSH is coming out. Once the follicles are growing, estrogen is coming out, and the woman will stop bleeding. All right? You can see the follicles over here starting to grow, the ovarian hormones. Estrogen is going to start coming out heavier, or coming out higher on day 5, 6 or so. You can see it's starting to raise here on day 6 because the follicles are growing and releasing and secreting estrogen at this point. The body temperature we'll talk about later, but right now it's just level. It's a normal 98.6. Are you okay with understanding what's going on with this graph? Okay. I'm going to have something similar like this on your exam. You've got to follow it. All right, now look at days 6 through 13. We call it the proliferative phase. Things are growing. Proliferation means to grow. You're going to proliferate your army. Things are going, your army's growing, okay? So day 6, one follicle matures. All the others regress. We explained that earlier, right? You have thousands and thousands of eggs that grow at one time. Follicles grow at one time. There comes to a point about day 6 or 7 where God or whoever chooses to say, that's the one I want, and that's the one that's going to grow, and the others will die and regress. Okay? If they pick 2 and say, hey, I like that one and that one, then these 2 will grow. Theoretically, they will ovulate, and you could have those 2 fertilized by 2 different sperms and have paternal twins. But normally it's 1. Day 7 and 13, that follicles can continue to grow and is going to continue to release estrogen. Estrogen is going higher. It's a growing follicle, it's getting bigger, it's going to release more. Which means the estrogen is going to target the endometrial lining and start making it thicker. Because there is no endometrial lining, you shed it off, but now it starts to build it right back up. A nice, healthy, clean endometrial lining with good blood vessels there. Day 13 is what we call the critical point. The growing, mature Graafian follicle is growing very big and is starting to bulge out of that ovary. And it's producing quite a bit estrogen. A lot of estrogen at this point. We call it the critical point. So the estrogen gets really high, and this is where we call positive feedback. When estrogen reaches very high, at this point, day 13, it does positive feedback. It sends a message to the anterior pituitary and says, we need the LH to grow, to get released even more than what you've been doing. It does positive feedback. And now the LH surges just on day 13. By day 14, that huge amount of LH makes the egg out of the growing follicle pop out. LH is triggering ovulation, making it rupture out of the ovary. Once the egg comes out of the ovary, the area, the follicle that it just came out of, is a critical thing for you to know. It becomes what we call the corpus luteum. The corpus luteum in the ovary is a big gland that is going to release more hormones. Now, some women can actually feel that rupture. They feel pain on their side there. Sometimes it's on this side, sometimes it's on that side. Because it depends on when the rupture occurs. We call that Mittelschmerz. I know it's a crazy, funny name. Anybody speak German? No? Mittelschmerz. Middle means middle cycle. Schmerz means pain. So this is the pain that happens in the middle of the cycle, right in the middle. Day 14 of a 28-day cycle. Makes sense. Some women get this so bad that they're in bed for a few hours, maybe for half the day. Others don't even realize it. And sometimes you feel it, 2 months you don't feel it. So we can't really rely on that to say, hey, look, you ovulated today. Okay? But it's nothing to be concerned about. Take some Motrin to deal with the pain, but it's not something that's going to be life-threatening. It doesn't cause infertility or anything. Okay? We usually ask the woman, you get this pain every month? Every month. When does it usually happen? Does it happen during your periods? No. Just before? No. About how much? About 2 weeks after. I always get it. It makes sense when it would occur. Okay? And most of the time we just have to reassure that this is a normal thing for you. And just have to just with medication, like over-the-counter medication. Okay? So that's where the egg pops out. And the first place that the egg pops out is it goes into the pelvic cavity, because the fallopian tube is not connected to the ovary, that there's a space there. So the first place it goes is in the pelvic cavity, and then the fimbriae of the fallopian tube kind of move, and it's kind of a neat phenomenon that it actually knows where to go. It creates this little vacuum, and the egg goes there. But it goes to the pelvic cavity first. Hint, hint. Okay? All right, so let's see where we are now. All right, talked about day 1 through 5. Now, days 6 to 13. The endometrial lining is starting to grow. You can see blood vessels. I don't know if you can see it on this picture clearly in this room, but you see blood vessels start growing over here, and the endometrial lining is starting to grow, proliferate. Okay? Meanwhile, you've got the follicles here, developing follicles. There's one that becomes a mature follicle. LH surge goes up, and on day 14, the egg pops out. Ovulation. Now, a couple things happen here. First off, the red line up here is estrogen, but we have a new hormone that comes out, and it's labeled here in blue, and it happens when ovulation occurs. What hormone would this be? That's progesterone. Progesterone happens only when ovulation occurs. And it comes out of the corpus luteum. We're going to talk about that. Also, we'll notice that the body temperature goes up about a degree when ovulation occurs and stays at a higher temperature throughout as long as that corpus luteum is alive. So it stays up for the next 2 weeks. So that's also another marker to say, hey, look, you ovulated. The problem is, if you're going to use that method, you've got to take your temperature every day, not skip a day, every day at the same time and the same place. Don't take your temperature in your body, in bed while you have all the covers on, you do your temperature, and then the next day you want to do it right after you brush your teeth, because that changes the temperature, right? You got to do it the same place, the same time. And then if you're looking to see when you ovulate, that's when you say to your husband, husband, don't leave yet, come back, we got to do something. Like, oh, But you have to do it on that day that the temperature changes. If you skip a day, then you might be actually seeing that the temperature has risen on day 15 or 16, but you already missed it because it's already up there. Does that make sense? You got to know the first day that the temperature goes up to see when you ovulate. Okay. So, day 15 to 26, this is the secretory phase. And what happens here is that estrogen and progesterone are going to start growing now at a tremendous rate. And they're coming from the corpus luteum that was just born. Body temperature does go up about a degree, as I just explained to you. Okay? And it stays that way until menstruation occurs. Now, glands start developing in the endometrial lining. This is why we call it the secretory phase, because glands secrete. And you have these glands that are important for when we have the future embryo needing to implant in the endometrial lining. We've got to have glands to do that. And the reason why we have glands growing here, and these are the spiral or uterine glands, is because progesterone is doing that. Now, we have a lot of estrogen. We got a lot of progesterone. When you have a lot of this, it's now going to do the negative feedback that I showed before. It's going to bring down the GnRH. It's going to bring down the FSH. It's going to bring down the LH. Negative feedback. specifically days 23 to 26, the corpus luteum, assuming the egg doesn't get fertilized, the corpus luteum is going to start dying down. So it's about a week after ovulation. Because LH usually keeps that corpus luteum alive. But because you have a lot of estrogen and progesterone, it's telling LH to go down. And therefore the LH is going to make the corpus luteum die. When the corpus luteum starts dying down, you're going to eventually have less and less estrogen and progesterone because that's where it's coming from, the corpus luteum. So let's look at where we are. Yellowish area here is ovulation. And now, look at what's happening with the endometrial lining. You have nice blood vessels in there from the estrogen before, but they continue to grow. Estrogen is going to make the blood vessels grow in the endometrial lining. But you also are going to find these endometrial or uterine or spiral glands growing also during the secretory phase to help with implantation of that future embryo. Meanwhile, in the ovary up here, the corpus luteum has been born and is producing all that estrogen and progesterone to make this a nice, suitable environment for the embryo. Progesterone is going to be very high during this time, and also estrogen in red here, there should be another bump up here, but it's still high. And the body temperature, as you can see, stays up a degree until the next menstruation occurs. Soon the corpus luteum is going to start dying down because fertilization has not occurred, and is going to start forming what we call the corpus albicans. As I explained to you, the reason why we do this each month, your body assumes it's going to get pregnant. We all know it's not going to happen. You don't get pregnant every month. But the body has to make a nice, good, healthy environment for this implantation of the embryo. So every month it's going to prepare it, thinking that it's going to get pregnant. If it doesn't, it sheds away. We've got to start from scratch. Day 27 and 28, the ischemic phase. This is where, because we have so low levels of estrogen and progesterone, the endometrial blood flow is going to start cutting down. Ischemia. That's why we call it the ischemic phase. And this is due to low levels of estrogen and progesterone. And once there's so little blood going to the endometrial lining, the endometrium itself is going to start shedding or sloughing off. Now, some books don't put the ischemic phase in there. I like to put it in there because it helps students understand that. Otherwise, they would have just continued to call it the secretory phase. But it's just 1 or 2 days before menstruation, and it helps to organize things with students' heads with that. So, the last few over here, last few days, remember, the corpus luteum has now become the corpus albicans, died down to the scarred tissue. Progesterone is going to start going down. Estrogen will start going down. This is going to make your body temperature go back down to a normal level. And you'll also see that the blood vessels here, if you can see it close up, the blood vessels are starting to break down over here. And then we repeat the whole cycle. Is that how it was taught to you in 5th grade? Okay? This is another way of seeing it. I want you to understand the graphs over here. What I like about this is 2 things. Besides, you can see the endometrial lining going over here, dying down, starting to build up, secretory glands are forming here, and then it dies back down. You can see how the ovary turns, the different phases of the follicle, primary, secondary, tertiary. Here's ovulation, pops out, corpus luteum, starts enfolding on itself, becoming corpus albicans. But this one, what I like about this is it also shows us the FSH and LH levels. As I was explaining to you, you've got this surge of LH just before ovulation. That's what causes ovulation to occur, is the LH surge, luteinizing hormone. And the other thing that I like about this a little bit better is that in this area here, you're seeing, this is estrogen, all right? It's a certain kind of estrogen called estradiol, just called estrogen, called a day. So estradiol or estrogen, there's a hump up here, and there's another hump over here. You see that? So the peaks of FSH and LH are over here. And then what I have here, estrogen is what we call bimodal. It has two elevations from two different sources. There's one there, and there's one there. And this is how I would ask questions on a test. Put in this graph here. I might say the source of estrogen levels being high here is from the corpus luteum, corpus albicans, the growing follicle, anterior pituitary, or endometrium. Again, the high levels of estrogen that's occurring over here, like day 20, is due from the source of the corpus luteum, corpus albicans, endometrium, anterior pituitary, or the growing follicle. Where? Where is it coming from? Corpus luteum. Where is the source of estrogen coming on over here? I'm sorry? Estrogen doesn't come from the anterior pituitary. No, it's before ovulation. Where is the estrogen coming from over here on day, let's say, 12? From the growing follicle. My suggestion is, I know this is hard, but this is putting together endocrinology. You have a final exam that's happening in a couple weeks. This is a good opportunity to go back and find out where all your hormones come from, like doing that chart again. Because it's going to be on your final exam, I guarantee it. You just have to put it all together. You've got to know where the different sources are, and where they go, and what they do. No, FSH comes from anterior pituitary. FSH comes from the anterior pituitary. Estrogen comes from the ovary. But what part of the ovary? The corpus luteum or the growing follicle? Those are two, but we didn't talk about another one. The placenta, should there be a pregnancy, which I got to do for you now. Okay? Got to put it all together. Okay, this is another way of looking at it. I'm not going to go through it, but step by step. Believe it or not, this is the menstrual cycle, but it's put into here. Actually, it's the ovarian cycle, but it's all put together in this way. If you follow it step by step, 1, 2, 3, all the way to 8 or whatever, it'll make sense.
Female reproductive cycles are initiated at puberty, usually between the ages of 10 and 14. Each reproductive cycle, which averages 28 days, consists of a sequence of changes that occur in the ovaries and uterus. During each reproductive cycle, gonadotropin-releasing hormone, or GnRH, from the hypothalamus stimulates the anterior pituitary to release two gonadotropic hormones, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. The target organ for these two hormones is the ovary. Each female reproductive cycle has two components, the ovarian cycle and the uterine cycle. Ovulation occurs on day 14 of the 28-day ovarian cycle. The 14 days prior to ovulation are known as the follicular phase, while the 14 days following ovulation constitute the luteal phase. The ovarian cycle is regulated by changing levels of FSH and LH. Ovulation occurs on day 14 of the 28-day uterine cycle. The 14 days prior to ovulation are subdivided into a menstrual phase, days 1 to 5, and a proliferative phase, days 6 to 14. The 14 days after ovulation constitute the secretory phase. The uterine cycle is controlled by the ovarian hormones, estrogen and progesterone. The events in the ovary prior to ovulation constitute the follicular phase of the ovarian cycle. In the first 5 days, increased GnRH stimulates the anterior pituitary to increase production of FSH and LH. This stimulates primordial follicles in the ovary to mature into primary follicles, each containing a diploid primary oocyte that is arrested in prophase 1 of meiosis I. At the same time in the uterine cycle, decreasing levels of progesterone lead to sloughing or shedding of the endometrial lining. This is the menstrual phase, commonly referred to as a woman's period. In the ovary during the second part of the follicular phase, days 6 to 13, a small number of primary follicles form secondary follicles. About 2 days before ovulation, under the influence of increasing levels of LH and FSH, the follicle expands to form a swelling on the surface of the ovary. Approximately 16 hours before ovulation, the levels of FSH and LH surge to cause the final maturation of the follicle, now called a mature or Graafian follicle. Just prior to ovulation, the primary oocyte completes meiosis I to form a haploid secondary oocyte. Simultaneously, the lining of the endometrium begins to reform under the influence of estrogen produced by the ovarian follicular cells. This is known as the proliferative phase of the uterine cycle. As the level of LH peaks, proteolytic enzymes produced in the follicle cause its wall to weaken and rupture. Ovulation is the release of the secondary oocyte from the mature follicle. After ovulation, the ovary enters the luteal phase of the ovarian cycle, days 15 to 28. During this period, the remaining ovarian follicular cells form a corpus luteum, which produces the hormones progesterone and estrogen. Progesterone and estrogen from the corpus luteum stimulate further thickening of the endometrium in the secretory phase of the uterine cycle, days 15 to 28. If fertilization and implantation occur, cells at the implantation site in the uterus begin to produce human chorionic gonadotropin, or HCG. HCG prevents degeneration of the corpus luteum, so that elevated progesterone and estrogen levels are maintained to prevent shedding of the uterine lining at the end of the uterine cycle. After 8 to 12 weeks, the corpus luteum ceases to produce progesterone and estrogen and degenerates to become the corpus albicans. The placenta in the uterus replaces the corpus luteum in producing progesterone and estrogen. If fertilization does not occur, the corpus luteum becomes a corpus albicans by the end of the cycle. This leads to decreased levels of progesterone and estrogen and results in menstruation and the beginning of the next uterine cycle.